Western civilization is moving closer to a point of irreconcilable, unstable equilibrium, as frighteningly increasing numbers of people trust nothing. Media, academia, and especially the governments are no longer held in high esteem. Regaining trust is often impossible after betrayal. However, transparency is essential to any healing process, and that is the essence of the Don Sullivan Show. Please listen to the team explore, probe, and debate cutting-edge science, technology, and computing. Play ball! Hello, folks in the audience of the Don Sullivan Show. Welcome back again. We've obviously done a lot of different episodes and a lot of different subjects in the last couple of months. Today's, I think, is one of the more important, if not one of the most important. The subseries of medicine is going to branch off into the subseries of infectious diseases. And today I want to welcome back my dear friend and the person I think is one of the top experts in the United States on the subject of human immunodeficiency virus and AIDS, Dr. Theo Hodge. So say hello, Theo, and I'm going to talk a little bit more.
Hello! From Washington, D.C. It's great to be back on the show, and thank you, Don, for having me.
Theo has become the go-to medical specialist for the Don Sullivan Show, and I'm going to use him as much as he doesn't get tired of me, which hasn't happened in 45 years. So I expect it won't, but you never know. I'll try to push it as much as possible because there is such a breadth and depth of incredibly valuable information here. Theo is an internist. He is also, I will say it, even if he won't, he is an infectious disease specialist. And he has a particular community he's going to talk about and focus on in Washington, D.C. But this is a disease that has obviously been around for a very, very long time, has tremendous political implications for most of our lives, still exists in its horrific forms all over the world, particularly in Africa. To a large extent, it has been gotten under control here in the U.S. There are interesting questions about the present state of treatments that Theo and I are going to, and Steve is here, I'll have him introduce himself as well, going to talk about, because I really want to get an understanding of exactly what the verbiage means, the terminology means, and particularly the marketing, because I'm in marketing, Steve's in marketing, and we don't trust marketers in general. So we really want to get an understanding from a true expert, that is Theo, on what all of that means. So before I get too solemn here, Steve, say hello, Steve.
Greetings from the Garden State. Today's episode is brought to you by License Fortress, the industry's first and only software asset management firm to offer both a financial and legal guarantee at its highest level of service. Whether it's Oracle, Microsoft, or VMware, License Fortress helps organizations stay compliant, avoid audits, and save money. You can learn more at licensefortress.com. And please support our producer by visiting axedinc.com. That's AXTINK.com. Subscribe to his YouTube channel and help support his efforts to create humorous animation. And get off of double secret probation at that crazy college of his. Back to you, Don.
Keeps happening. We keep hearing about that. I don't know.
He's got some issues.
The waiver, Steve. All statements by the host and guests on the Don Sullivan Show are the personal opinions of the host and the guests, all of who agree that the following content is the property of Xanalytics, LLC, to be used publicly and exclusively on the Don Sullivan Show. And again, welcome back to the shows and my favorite physician, Dr. Theo Hodge. And Theo, I'm going to turn this over to you because I really would love you to talk for a while, and I will shut up, and that's very hard for me. I will shut up and give us a short history of HIV and AIDS, starting with its discovery in Africa in the 60s.
Okay, well, let's take a walk into history. And to be perfectly frank with you, it was almost 100 years ago that it was felt that HIV came into being. It was felt to have originated from the simian immunodeficiency virus, which is in primates. And that was felt to have occurred trans-species contamination, if you will, or transfer.
Zoonotic, I think the term is zoonotic when it
Yeah, it
transfers
was,
between
well,
species.
it was all thought to be secondary to bushmeat. And in this case, it was chimpanzees. Bushmeat can be, bats. It can be even reptiles for that matter. But in this case, it was thought to be bushmeat involving chimpanzees, and the hunters became exposed to the blood. And with simian immunodeficiency virus, I mean, there were, as I said, there was transfer of that virus to humans, and it usually will result in limited disease to nothing. But somewhere along the line, probably somewhere in late 1920s, 29, by some sources, that virus was transformed into HIV and into the particular HIV that has become a pandemic. HIV is
That
called
was just a mutation of the virus,
it's a
you think?
mutation of
Well,
a chimpanzee virus. So
yeah.
it went from
Again,
being a
zoonotic.
chimpanzee virus to a human instead of simian, which is usually relating to primates, other than HIV, other than human, to a human immunodeficiency virus. So yes, there was a mutation somewhere along the line after having had that virus exposed to humans. And again, the mode of transmission at that time was thought to be bushmeat. And in this case, it was chimpanzees. So supposedly that happened around 1929, and the virus evolved to human immunodeficiency virus group M, which contains the two major types of HIV, HIV-1, which is the majority of HIV infection in the world, and HIV-2, which tends to be contained there in Africa. The first known, and this is going back looking at blood that was frozen, HIV virus found in humans was thought to be around 1959, and that was in what is known as the Belgian Congo. So that was discovered when they looked at frozen blood.
Now, for the audience, the Democratic Republic of the Congo.
Yeah.
Right?
And so because you're kind of tracing the history back, and you're saying, okay, how in the world did we get this virus? So the simian immunodeficiency virus is where they started out with, and they were like, okay, wow, it produces the same exact syndrome does human immunodeficiency virus. And so, well, how did this go from chimpanzees to us? Well, again, start to be bushmeat. When was the first known human with HIV? Supposedly in 1959, from this person's blood that they isolated. They went back, took it out of the freezer, and looked and saw HIV there. And that was in the Belgian Congo. Supposedly HIV then came from Africa to the US in the 1970s. And in 1981, the CDC described what was known as GRID, which was gay-related immunodeficiency. And that was because they noted all these cases that were being reported among gay men with pneumonia and these unusual cancers. And of course, the gay men at the time were very young.
Pneumonia is pneumocystic pneumonia in particular, and
so the
others.
pneumonia that, in particular, that they were being diagnosed with is what we'll get up to in a moment. It was an opportunistic infection. It was a pneumonia that nobody gets diagnosed with, and it was called pneumocystis carinii, which is a fungus, which ordinarily your body would just say, hey, here's a little pneumocystis carinii, and your immune system would jump up and go poof, and you would never, ever become ill. Well, that wasn't happening. And so in 1981, that's what they described is what was known as GRID. The next year, they renamed it, because the CDC actually did call this GRID. They renamed it as the acquired immunodeficiency syndrome. So it went from GRID to acquired immunodeficiency, as people began to recognize that this actually occurred to people outside of the gay community. By 1983, there was kind of a race between the U.S. and France to actually identify the organism or the infectious agent that caused the acquired immunodeficiency syndrome. And so HIV itself was identified. by both France and the US, well, around the same time, 83, 84, as the causative agent to the acquired immunodeficiency syndrome. So that's a really brief history of how we went from, chimpanzee virus to this global or pandemic, as we call it. There's about 40 million people in the world living with HIV. So it's very much
Presently,
present.
now, it's 40 million
About
people
40 million
as an
people,
estimate.
40 million. This is an entire world, 40 million. And the U.S. is about 1.2 million. So you're like, well, we only have 1.2 million. Where's the rest of the 40 million? Well, the majority is in Africa. Africa has the largest amount of people living with HIV.
So is that still in sub-Saharan or Central Africa?
Exactly. That's where the majority of people you see living with HIV.
HIV too, does that present differently, Theo? You mentioned the two different strains, and one was mainly in Africa.
That's a very good question. It does present differently, and it actually is treated differently. The drugs that work, there's an entire class of drugs that work to actually block the virus, if you will, in HIV-1 that do not work for HIV-2. So the syndrome that it creates is the same. So in terms of treatment, it's different. But in terms of the ultimate outcome, if the virus was left unchecked, it is the same. You end up with acquired immunodeficiency syndrome and all the drama that happens once you hit that.
So you refer to it, and it's always been referred to colloquially and medically now as a syndrome, as AIDS. How does the virus, and what does it do to the immune system to cause this syndrome, which is kind of a different code word for a disease, right?
Well, it's a collection of medical ailments. So the way the virus works is that it attacks your CD4 or /T cells. So I like to, in that directs your immune system. So the way I usually explain it to my patients is when we're looking at your immune system, we're essentially looking at a teaspoon of blood. When we're assessing your immune system. And in terms of your immune system, that is composed of white blood cells, and there are various different types of white blood cells. So I am Don, as you know, I've had time in the military. So when I began explaining this, I was in the military. So I would explain to my patients, in that teaspoon of blood, all the white blood cells.
Theo wants to say he was in the military, but let's get clear here. He was on the border of Kuwait when Operation Desert Storm, the greatest operation in the history of military, actually went over and destroyed Saddam's army. And Theo was part of that. Just to let everybody know. Go ahead, Theo, with your humility there. Please continue.
No problem, Don. But usually what I say, okay, we look at your immune system, and we usually, all those tubes of blood they draw, they really want to know what's in a teaspoon. So they spin everything down, they look at a teaspoon. And so they're looking at your entire army, if you will. And in that, they will say, okay, your white blood cell count is this. So if I say to you, hey, Don, your white blood cell count is this, 4.2. Well, 4.2 means that you have 4,200 white blood cells that comprise your army in that teaspoon of blood. So there's your army, 4.2, which is 4,200. Now, remember, with an army, as with other parts of the military, there is, there's rank order. So if you split it into the basics, you have the officer side of the house and you have the enlisted side of the house. In the officer side of the house, what you'll find, and when you're looking at your immune system, they will say what percentage of those white blood cells happen to be officers. Well,
say that word again.
Officers, okay?
Okay. Oh, officers.
Officers,
okay,
right.
Sorry. Yeah.
So, again, the officer side of the house versus the enlisted side of the house. So once you get the number for how many officers you have, then you say, well, how many of those officers happen to be generals? And when you get that number, you have your T cell counts. So, or CD4 counts. So your CD4 counts are the generals of your immune system. They direct all the rest of your immune system in fighting off infection. So when that little pneumocystis carinii pops up, the general will say, hey, you white blood cell, you go over there and you kill it. And that's what happens. Poof, 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 poof. Well, unfortunately, the HIV virus doesn't infect some little teeny neutrophil, which, by the way, the neutrophil happens to be on the enlisted side of the house. They're the privates of your immune system. They're the first to die in the fight against infection. Because remember, your white blood cell army is fighting off infection 24/7. Not 2 hours a day, not 3 hours a day, 24/7. So this is an ongoing thing, and making sure that, I mean, it's sort of like, again, in basic terms, your white blood cell army is very much like our U.S. Army. And our U.S. Army is supposed to be keeping enemies out of the U.S. Well, you know what? Your white blood cell army does the same thing. It keeps infection out of your body. And infection can be divided into a few things, such as, funguses, parasites, viruses, bacteria. All of those things constitute infection. And your white blood cell army is responsible for keeping all that stuff outside of your body. But as I said, there is a chain of command. And at the top of the chain of command is the T cell or CD4 cell. And it so happens that the virus infects that cell. And in infecting that cell, it actually transformed the cell into a baby-making factory. And so you make millions of viruses, and then your body responds and says, hey, this is a bad thing. And it kills, or, the T cell self-destructs because your body jumps up and starts beating down on the T cell and destroying it. And, producing all that virus also helps to destroy the T cell. Well,
that's why the T cell count is the most important metric.
That's exactly right. And that's why, when we talk about the two things to remember most, my patients have to remember in terms of their HIV is, what is your T cell count? Because I always instruct them, hey, in that teaspoon of blood, you should have about 1,000 generals. And you know what? It can range anywhere between 500 and 1,500. Once your T cell count drops to 200 or below, that's where the acquired immunodeficiency syndrome comes up. And what does that mean? Well, that means there's not enough generals to direct the rest of your army. And I usually explain to my patient, just imagine that you're the star at work. And so your supervisor could care less about being around because they know the job will be done. But your colleagues, if your supervisor isn't around, don't do jack. Nothing gets done. Well, that's the same thing that happens in your body. Once you don't have enough generals around to tell everybody what to do, the rest of the cells are like, well, you know what? I see that little infection over there. I see that little virus over there. I see that fungus, but I ain't dying for him today. Ain't nobody here to make me die for him today. So that's a problem. That is a problem. So when your T cells drop below 200, that puts you at risk. Well, it's by definition AIDS, or the acquired immunodeficiency syndrome. But when we talk about the syndrome, what that means is that there are a collection of what we call opportunistic infections. That is because now they have the opportunity to infect because there's nobody there to say kill. That comes up. So right around 200 comes pneumocystis carinii, which they've renamed pneumocystis jirovecii. That is a fungus that would never, ever, 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 ever make you ill. And that fungus, you breathe it in, and usually your body would say, poof, wouldn't be a problem. But since the T cells are not there to say, hey, kill, that fungus multiplies and grows in your lungs, and you, the patient, develop a fever, a cough, and shortness of breath. There are other things that happen around 200. That includes Canada.
Lesions.
Hmm?
I'm sorry, Theo. I'm remembering that movie, and the band played on. The guy had purple
That
lesions on him.
That's yes. So that particular infection is human herpes virus number 8, which causes Kaposi sarcoma. That
Oh,
comes
okay.
right around 200 too. Now, again, it is an infection. It's human herpes virus number 8. That's usually kept in check because your T cell says, "Hey, human herpes virus number 8, you stay over here in your little jail." But because it's not there, that human herpes virus number 8 goes on to develop Kaposi sarcoma. And Kaposi sarcoma is classically those big old purple lesions that you saw and the bad playing on. But Kaposi sarcoma can involve every organ of your body. The most common organ it involves is your skin. And again, that happens right as your T cells are going below 200. The fungus Candida, which is a fungus, and if you were to ask somebody to open their mouth with Candida, you see these big old white lesions, and they can go all the way down their esophagus. And so what happens is the person can't really swallow. They start losing weight. It can be drama.
How many of these opportunistic diseases, or I guess they're all diseases, can occur?
Oh, multiple. So back in the day when we really didn't have treatments for HIV and I was in the hospital taking care of people all the time, it was a rare event that I saw one. They usually had multiple things because, again, you don't have an immune system. And again, most of the things I just described occur once you drop below 200. Once you drop below 100, one of the things that most prominent is toxoplasmosis, which usually is found in kitty cats. So that's where.
Yeah, I was going to say it's like a cat thing.
It's a cat thing. Well, the problem is, of course, doesn't do a thing to the cat, but you breathe that in, and toxo likes your brain, not like pneumocystis, which loves your lungs. Toxo likes your brain, and so it multiplies and grows in your brain, and you, the patient, develop a headache and a fever, and usually you're going to have a grand mal seizure somewhere along the line. So that's how I used to see that present back in the day. So
this is an all the above horror show.
Oh, it wasn't cute. So again, these were potential things. They doesn't mean you were going to have these things happen, but the likelihood of them happening dramatically decreased because there was no generals there to say stop.
It also sounds similar to what could happen to a child that has no immune system and needs to be in a bubble.
Exactly. It's just another way of having an immune system destroyed. In this case, it was because of a virus that destroyed the person's immune system.
And it just happened to be hitting the T cells, and we know the difference, and we all learned this during COVID, I hope, the difference between T cells, or at least the names of T cells, and killer B cells, I guess, that would go after disease and so on. But this is the T cells that the HIV virus, for whatever bizarre Darwinian reason, happens to have an affinity for destroying.
It does, absolutely. And once you get down below 50, that is where classically people, it's the classic representation of AIDS. That's where people start losing weight. That's where people develop fungal infections of the lining of their brain and spinal cord. And that's cryptococcal meningitis. That's where people develop cancers in their head, or CNS lymphoma, meaning you have this lymphoma in the middle of your brain. That's where cytomegalovirus pops up. Most people have been exposed to cytomegalovirus, but when you have no immune system to keep it in check, it pops up in your eyes, and it's drama because you go blind. So those are some of the opportunistic infections that make up the syndrome known as AIDS.
And that's why it's a syndrome, because there's many of these various different opportunistic diseases.
Exactly.
All right, see, this is so important to clear this up for an audience like this, to understand the real facts behind the history and the present situation. And I'd like to extend that particular point to another very important point that was a panacea during the 80s and then into 1991 in particular. So, Theo, how does it transfer between, because viruses, obviously, we've all spent 5 years ago, went nuts literally worrying about a virus that was airborne. And there are many, but that's not the case with HIV, right? And do tell us, how does HIV transfer from person to person or from a simian?
So here we are in 2025. So you're walking in my office and you say, hey, how is HIV transferred? I break it down first into three different parts: sexual transmission, percutaneous transmission, and perinatal transmission.
All right, explain both of those.
So, sexual transmission, here are the bodily fluids, and this is exposure to mucosal surfaces, such as the lining of your anal canal or vaginal tract or your urethra and your penis, or your mouth for that matter, because that's a mucosal surface as well. So the bodily fluids that actually transmit HIV are blood, semen, pre-cum, which is a biggie, because people don't seem to realize that. They're like, oh, well, I pull out before the person comes. And I'm like, hello.
So that's not semen? The pre-cum?
No, semen includes sperm, which pre-cum is all of the liquid that your prostate makes to make sure the sperm has nutrition and all of that as it travels.
Like the lube, right?
Right, yeah. It's like the lube. So there's a big difference between pre-cum and an ejaculate. So, and that usually, there's some men that have a lot, there's some men that have none, but I mean, it is super concentrated with HIV. So that's something that I really need people to understand and recognize because of oral sex. People are like, well, I let them go before, they ejaculate in my mouth. I'm like, well, hello, if you taste any salty anything in your mouth, that's pre-cum. And that can expose you. And people are like, well, I heard that if you give oral sex, it really is less likely that you'll come down with HIV. And that's true. But if you did something like flossed your teeth right before you gave somebody oral sex, that's a highway into your body. So, again, things to think about. Now, in terms of the other bodily fluids that transmit HIV, there's vaginal fluids. Some people would consider anal fluids. And then there is breast milk. Breast milk is a major transmitter of HIV. And that is how some babies end up getting HIV. So those are the sexual ways so that you transmit HIV. HIV is not transmitted by sweat, is not transmitted by urine. It is not transmitted by saliva, which is a big deal because people are like, well, I heard if you kissed me that you would give me HIV. No. Now, don't get me wrong.
Maybe unless your mouth's bleeding, maybe. But yeah,
right. If you have blood in your mouth, that's totally different.
And sweat either, right? No, sweat is not a transmitter.
Sweat is not going to do it. Sweat is not going to do it. And
there was confusion over that back in the day, right? Because they were worried about Magic Johnson.
We'll get to Magic here in a few minutes. But yeah,
in the community that you can get HIV from kissing people or sweating on them. I mean, it's just, or peeing on them. I'm like, no. And for me, it's a big deal because people gave that information to young women so that they wouldn't kiss their babies. I'm like, y'all have lost your mind. You cannot tell a mother she can't kiss her child because she has HIV. That's crazy. So
I have a question for you, Theo. Growing up, there was a man that lived across the street from us, and he was HIV positive, and eventually he died of AIDS. This was the early 90s, and my parents knew for some period of time, that he had this issue. And my mom used to worry that a mosquito would go over and bite him and then come into our yard and bite us because it's blood related. But why is that implausible? Obviously, that's not a way it spreads. But
you have to have enough.
Used to wonder back in the day.
Right. So what we found now, which is going to lead to one of the things that Don asked about, is you have to have a certain amount of HIV to actually cause an infection. So, and we know that now, and we talk about, so let me backtrack. just a little. So, now we're in an era where we want to end. We have this whole end the HIV epidemic thing that has been, you know, set forth by our government, and we're supposed to have reduced at least in the U.S., and we're specifically talking about the U.S. infection rate down by 75% by this year, which ain't gonna happen, and 90% by 2030. So a reduction of 75% would mean we'd have about 9,600 new infections for total for the year in 2025, and 3,000 total for the year in 2030. And I can tell you in the year 2023, we had 39,000, which of course is a big drop from like 50, 60 back in the day, but we've become rather stagnant. And in terms of ending the HIV epidemic, I remind people all the time, it begins with a test, and everybody should have a test. And then in 2006, the CDC said that everyone should have a test regardless of risk. So even though people walk in my office and say, why would you think I should have a test, blah, blah, blah. I'm like, that's cute, but you need to have at least one test on your chart.
Do they screen your blood from that when you have a standard blood test for a physical, or is that
is typically at the time that I do it? It's a standard blood test that I do at the time of a physical. And because of my office, no one gives me any drama. I'm like, look, hello, this is what I do. So no one's going to give me any drama when I give them an HIV test. But if they do, I explain to them, look, this is all about your health. I just need to make sure, because I've heard it all before, I wouldn't have HIV. I don't know why you would think. And then test comes back positive. And then, you have all this drama. So I'm like, look, I'm here because I'm uplifting you and holding you to the light. And if I'm going to do that, then I need to make sure that we address all aspects of your health, of which your sexual health is a major part of your overall health. So let's get the HIV test. And if the HIV test, when it comes back, as I said, you only get that first one regardless of risk. Any others are based on risk. So regardless, if the test comes back positive, if you put everybody on therapy that is positive, and they become undetectable. And what does that mean? What is undetectable? Undetectable means that the test that I'm using to measure how much virus is in a teaspoon of blood can't find it. So the test that I use in my office goes down to 20. So if you have 19 little HIVs floating in a teaspoon of blood, the test will say undetectable, because it can't go down to 19. It can go down no further than 20. Well, we also know from testing that if you are undetectable, that it also means you can't transmit the virus. Undetectable equals untransmissible. U equals
Okay, so let me stop you there, because we've talked about this, and quite honestly, I believe you because I believe everything you say. But to me, that initially seemed like a pretty classic marketing slogan, because it was there. It is there.
It is.
How can you be so sure?
Marketing. We've had gobs of studies with thousands of sexual acts where the HIV, and this is in discordant couples, meaning one is positive and the other one is negative, where if the HIV positive partner has a viral load of less than 200, this is where we're talking about concentration here, less than 200 copies in a teaspoon of blood, they can't transmit the virus. And I mean, this is not like two people. This is thousands and thousands of sexual acts where they did not find one new infection.
All right, so it
doesn't
mean you're HIV free, but it means that
you can't transmit right. No, you're not HIV free. We haven't come up with a cure yet, but we have come up with a way to prevent an HIV positive person from transmitting the virus to an HIV negative person.
So, but you said can't, as opposed to we have never seen it. Are you confident enough? And I am, because you've told me.
And I'm telling you, the only time they saw HIV transmission, and Don, this is not one study, there were multiple studies. The only time they saw HIV transmission in that setting was when the HIV negative partner stepped outside of the relationship and had sex with another HIV positive person who was not undetectable.
Oh, gotcha.
So the drugs, and there are many of them now. Brictarvy was the first one that I saw. You really believe in?
Here's the deal with HIV medicine, and I explain this to my patients, that HIV medicine is viral birth control. Viral birth control. It stops the virus from having babies. That's what HIV medicine does. It doesn't kill the virus. It prevents it from
technically,
propagating.
Shall we say, it prevents replication of
it
the
does.
virus.
That's why I say it's viral birth control, because my female patients get it right away. They're like, oh, okay, no babies.
So it's antivirals, basically. Is that
all
accurate?
Antivirals are viral birth control. That's what they do. So let's say the virus must go through 8 steps to produce a baby. You have to interrupt reproduction, that reproduction cycle, at least 2 steps. Doesn't matter which 2 steps, but you must interrupt it at least 2 steps in order to stop reproduction altogether. If you do that, your viral load drops dramatically to undetectable. Of course,
and you have to keep doing that, though. You like once it's really low, do you stop the therapy, or do you have to keep doing
just
it?
imagine it. Again, using the analogy of viral birth control, you stop your viral birth control, you're going to end up having babies. Well, that's the same thing.
So you got to keep this therapy going.
You
for
have
life,
to keep the therapy going. There's no ifs, ands, or buts. Just like a woman taking birth control, if she stops, she's going to end up having a baby.
You're going to have a baby. Okay,
right.
Gotcha. I'm getting it now.
So the same thing with HIV medication, you have to make sure that you continue to take your medication. Now, with that said, brief history of the antivirals or the viral birth control. The first one was introduced in 1987. That was AZT. This originally introduced as a chemotherapy drug. Horrible side effects. Horrible.
Very famously, that's what Magic took when...
Back in the day, and we'll get to him. So in 1996 came highly active antiretroviral therapy. That's where we actually found out that you had to interrupt the virus at least 2 different parts of its reproduction cycle. Otherwise, you couldn't do it. Before then, we kept interrupting at a single site. And so the virus rapidly adapted, and all of a sudden your viral load would go back up. Well, in 1996, we finally came up with, you need to have multiple sites to attack. And at the time, the drug, as they call them, cocktails, very much like liquor, because you had a little this and a little that. There were multiple pills. So you had up to 30 pills a day, and you were taking them multiple times a day. But at the time, because people were dying, as a healthcare provider, I just wanted to see you live from today to tomorrow. So that was my goal and my focus at a time when all these people were dying. I just wanted to see, hey, can I get you to live a little longer than all these other people have lived before? Then around 2006, where we developed our first single tablet regimen, where you have multiple pills or drugs in a single tablet. And again, you were attacking at least 2 of the steps that were necessary to produce a baby. Suddenly, you went from having all these horrendous side effects, because they were horrendous, to having a more convenient regimen, because instead of taking 30 pills a day, multiple times a day, you were down to 1 pill once a day. So that happened in 2006 with our very first single tablet regimen. And then we've evolved, because remember, all of these regimens, essentially the bottom line is you had to take a pill every day. Because you had to have a certain amount of medication in your blood system at all times to stop all viruses from having babies. And if that medication fell to below the level you needed to stop all viruses, then there would be some viruses that would start to reproduce. And, the viruses, I tell people all the time, don't care nothing about you. All it wants to do is have babies. And if it has a baby in the setting of medication, the baby's going to have to be able to adjust. So if that happens, that means the virus has become resistant, meaning your medication doesn't work anymore. which is a problem if you develop resistance, because resistance is permanent, 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 permanent. So there
Is
are
that
some
an
drugs
issue
that
that
you
you
can't
see
take
going
anymore.
on? Is that an issue that you see going on with current AIDS drugs, resistance
Well, the
developing?
problem, so now we have drugs where it is much harder to become resistant. But the problem is I have had patients now that started out with me, and Don remembers when I had black hair and I was at least 147 pounds when I was 147 pounds in college. Can you believe that? Because I ain't nowhere near that now.
You can lie. This is just
And
audio.
coincidentally, he was a 147 half mile or two, but that's
but but oh my goodness, I've broken my train of thought. What was I talking about?
resistance.
Oh, resistance. So,
Resistance
I
is
mean,
not futile.
so as these drugs began to evolve, the first drugs we had, it was very easy to become resistant to them. And so, as technology has developed, it's harder. It's not impossible, because if you mess up taking drugs enough, you will become resistant. But the drugs we have now, it is much harder to become resistant. So I'm less likely to run into resistance. But again, people have been with me nearly 30 years. So you have people who were on the very first regimens. And so they do have resistance. And resistance is permanent. Once you have it, you have it. Now, what has happened, particularly with my younger patients, is number one, now we've gone from convenience and less side effects to patient-centered care and quality of life. So, my younger patients, they don't know anything about AIDS. They'll look at me and they go, well, my grandfather used to tell me about his friend that was in the ICU. And I'm like, your grandfather used to, because they have no clue of what, people of my age group lived through. When I was in my 20s, you would go to the club and you would see somebody, and the next time you went, they weren't there anymore. And I was in my 20s. So this was a big deal. Or I would be in church and you would notice 3 or 4 people that were in the choir were no longer there. And they would say, oh, well, they had cancer. I'm like, what 25-year-old has cancer? I mean, as soon as, because you knew what was going on. Well, these, 25-year-olds today don't have a clue, because we were horrified back then. They're like, oh, yeah, I heard about this. And so HIV is it's all about wellness. So I never present, when I'm talking to my patients about HIV, as doom and gloom. You just don't do that. You just say, hey, this is what it can do. This is what you need to do to prevent it from causing this trauma in your life, and go forth and be fabulous and live your life. So with that, most people get it. And particularly now, because as opposed to before, where everything was at least a pill a day, now we have the injectables. So we've evolved from taking a pill every day to injections, which came about in 2021, where you can get an injection, or I should say 2, because it's 2 drugs, because now we're down. We used to have at least 3 drugs that you needed to take, and you could put all 3 in one. And now we realize, okay, since we only have to interrupt 2 of the steps in the reproduction of this virus, then why should we use 3 drugs? We can use 2. So in the case of the long-acting injectable that we use, it's 2 shots, a drug with each shot. And currently, you can do that every other month, which for many of my patients, they love it, because they don't have to take a pill every day. In fact, that's the biggest thing, is that Dr. Hodge, you have no idea, taking a pill every day has occupied such a large mental space in my brain, which I never realized until this. I mean, I have to tell you,
I imagine.
I was really shocked. I mean, I'm telling you, you mentioned one of the most popular drugs, Don. That drug happens to be the number 1 drug here in the U.S. in terms of prescription.
It's because I see it in the commercials.
Right. And that's one reason why that's why. But, there are other reasons, such as the drug it's hard to become resistant to it. You have, there are side effects, but they're very few compared to our earlier regimens. which had horrendous side effects from diarrhea to ingrown toenails. I mean, it was horrible.
Ingrown
Horrendous
toenail
types
is a
of
side
side
effect.
effects
Oh
with
God.
They hurt, Don. I've had
I know.
plenty of
I
those.
know.
So,
Many years
Theo,
ago.
I have a question. Back when I took health class in the early 90s, they scared you to death about AIDS. If you stepped out of line, you could get AIDS. I remember the video with Arsenio Hall and Magic Johnson, et cetera, et cetera. Nowadays, because it's not a death sentence anymore. It certainly was in the 80s. Do you think the younger generation doesn't care as much, isn't being as careful, or is that not what you're seeing
It
in
was
your
not a sense of
experience?
urgency in that
well,
way.
it's not, as I said, you don't have the doom and gloom that
Yeah.
surrounded me. And, what I was mentioning earlier about the test, everyone having to have a test, I mentioned that if you came back positive, you put people on medication and undetectable equals untransmissible. If the test comes back negative and you're at risk, then you put the person on PrEP. And PrEP is pre exposure prophylaxis. You're taking a
ask about that
medication to
too.
prevent infection. And so in today's society, we have PrEP and we have easy ways of taking PrEP. The first PrEP drug to prevent HIV came out in 2012. And it was FDA approved as a pill every day. And it prevented HIV infection, even if you're exposed, 99% of the time. So the drug
Do you
works.
take it every day or
every
just
single
when you're going?
solitary day.
It's not like
Now,
when you're going to have sex.
Say that. I'm
Okay.
sorry, Steve.
It's not like Viagra, like you take it when you're going to have sex. You take it every day.
Okay, so the oral agents are FDA approved to be taken every day. There is a study, it's called the IPREX study, where it was done where PrEP was on demand, pretty much like taking Viagra. And the way it was done, it was with a single drug. It was not with any other oral drugs. It was Truvada. You would take 2 Truvada 2 to 24 hours before your sexual act, and then a third one 24 hours after that, and a fourth one 24 hours after that. That was called PrEP on demand. That is not an FDA-approved way, but it
doesn't really work for spontaneous moments that well, does it?
Well, but there's scientific evidence definitely to back it up, so it works. It's just that because of, particularly when I'm talking about it, I have to make the distinction which drug it is, because the second oral agent, the first one that came out was Truvada for PrEP in 2012, and in 2019 came Descovy. So they're both FDA approved to be used every day. PrEP on demand the studies have only been done with Truvada, so I can't really say anything about Descovy. In 2021 came our first injectable prevention drug, and that was called Apretude, and that is given every other month after the first 2 initial injections, which are given a month apart. And as of June of this year has come our second long-acting injectable to prevent HIV. We're talking about PrEP here. So that drug is called Yeztugo.
So when you say prevent the HIV, you do mean prevent transmission from an external source.
Exactly. Or a sexual source. This PrEP is for preventing sexually transmitted HIV.
So not the other methods we're about to talk about.
It wouldn't work if you were like injecting dirty needles. It wouldn't do anything for that.
This way, the studies haven't been done for me to say that. The studies that have been done have been with sexual transmission. So when we talk about PrEP, we're usually talking about preventing sexual transmission, which is the majority of people acquiring HIV.
Is there a morning after pill for like?
Yep, there's PEP. There is post-exposure prophylaxis.
Yeah, if you like
where you
mess up one night.
Yeah, you take the entire HIV regimen. So PrEP is very different from, actually treating HIV. So PrEP is a single agent. Remember, I said for HIV treatment, you need to have at least 2 drugs attacking two different steps in the HIV cycle. PrEP, you're only doing one. So with one, you can prevent infection, but if infection actually takes hold, you need to be on the entire HIV treatment. So you're going to have to do more than just PrEP. PrEP is not a complete treatment for HIV once it's established.
Gotcha.
So you have to take PrEP. You can only give PrEP if the patient is HIV negative, which is a big deal. You cannot give PrEP to somebody who's HIV positive, because if you do, it's an incomplete regimen and the virus is going to become resistant to the drug you're giving because you've not fully suppressed it. And again, it's for survival of the fittest. So you're going to force the virus to produce a baby that can withstand that medication.
Yeah, that's not a good combo there, huh?
No. So you have to be HIV negative before you give PrEP.
Well, let's look at these other transmission methods, or these other ways that transmission can occur, and possibly the two most famous cases ever. We've already mentioned one of them, and there's been many famous cases, of course, but Ryan White, having likely been infected via blood transfusion, and of course Magic Johnson, who we saw at the World Series Game 7 the other night in Toronto and is totally fine, especially for somebody who's in his mid-60s, unbelievably so, who we to this day really don't know how the transmission occurred.
Arthur Ashe was a blood transfusion too.
It was definitely blood transfusion, and you know, so I've had so let's back up a little to Magic Johnson. So Magic Johnson is fabulous. I've had the opportunity to meet him. He's come to DC. He's made such a huge difference, particularly back then, because his transmission of HIV to him was thought to be heterosexual. I mean, you know, he's a basketball star.
It's certainly what he claimed, right? So that's my point. We don't really know. Yeah.
Well, I mean, heterosexual transmission happens. I mean, you know, it's less likely to happen from a woman to a man. But let's think about this. I mean, vaginal fluids transmit the virus. I mean, it's concentrated virus sitting in vaginal fluids. And, you know, you're pounding away. And some woman, and let's just say you happen to also have chlamydia. I'm not saying this would happen to him, but chlamydia causes all this inflammation of your urethra, which again, highway into your body. If you're pounding away and vaginal fluid is getting into your urethra, it's poof, it's in your system. I mean, it's not too hard to imagine how that might have happened. I mean, so in Magic's case, particularly in the African American community, this is what I would hear every day. He has money. He is taking something different than I am. He has money. He is taking something different than I am. I wish I could get what he's taking. And Magic was fabulous because he came to the community and said, I'm taking just what you're taking. And I have to do it every day.
AZT at the time, right?
Huh?
AZT at the time.
Well, no, he was actually by the time he came around, he had a complete regimen. So it was more than AZT. He was, and I can't remember, but I'm pretty sure he was taking. I
don't want to violate any 30-year-old
I want to say he was taking a single tablet regimen, our first single tablet regimen, but in
91.
So our first single tablet regimen had all the drugs you needed. All you needed was one pill.
Back there in 1991.
No, not in 1991, because in 1990, and he may have started with AZT because that was in 1987. In October of 91. And he may have taken a couple of, those single, only attacking one step along the way. But eventually, when he started traveling the U.S. to say that he was taking the same medication as everybody else, he was first of all undetectable, and he was on a fully suppressive regimen. And his big thing was telling people, I'm doing what you're doing. I'm taking my pill every single solitary day. I know how hard this is. My money is not doing anything in terms of my viral load being undetectable. I am just like you. I have to follow my doctor's directions and taking this medication on a daily basis. And that was transformative. That was transformative for so many people because they were like, oh, this person is like me. They have the same concerns about this virus destroying my body, but here they are living this life, looking good, because Magic had had the virus for a while by the time he started traveling.
Yeah.
And he was doing as his doctors directed and taking his medication on a daily basis. And it was very clear, and he made it very public, that his viral load was undetectable. And it wasn't because he was on anything other than what other people
let's
had
just
the opportunity to have.
That both he and Greg Louganis became Olympic champions.
Yeah.
After they were tested positive, or they knew it.
Now, I was going to ask, with HIV, if it's left untreated, what is the typical time frame for it to become AIDS? Is that kind of a little bit of a toss-up? My understanding, at least growing up, was, if left untreated, it could happen quick. It could take a few years or more than that.
So let's talk about that. That's a very good question, Steve. And that's why I always, when I'm doing HIV one-on-one, I will say, hey, at least looking back in observational recordings where you're just all you're doing is looking at what happened over a period of time. For people who started out with normal T cell counts, let's say there were 100 people who started off with a normal T cell count, which, as I've said, the average is 1,000. If they all came in at one time, you'd expect in 10 years that 80% of them would go from their 1,000 to less than 200. About 10 to 15 years, 80%. 15% would go in 2 or 3 years. Just poof, they're there. And then you have 5%, they never get there. And we don't know why. It's because maybe they have super duper immune systems that are able to keep HIV in check, or the virus they got wasn't as virulent as other people's, or some combination of the two. Those people I have run into, they're called, if they're undetectable, they have, and you keep testing for HIV, you're like, well, you're undetectable, you're not on drugs, this can't be. And they keep coming back undetectable. Those people are called elite controllers. Again, that's because their body, their antibodies are better than everybody else's because they're able to keep that HIV in check. And then there are long-term non-progressors. They're not undetectable, but they usually have viral loads less than 1,000, which means they can transmit the virus to other people. And their T cells never seem to drop. It is like 20 years later, and their T cells haven't dropped. And we don't know why. And there's controversy in the community as to whether or not these people need to be treated. Well, actually, the controversy is more of the elite controllers because they're undetectable. Not so much with long-term non-progressors where, the community is really like, you should be treated. First of all, because so you can't transmit the virus to anybody else. And second of all, the secondary effects of not having your immune system, although it may be slow, little by little, the virus is chipping away at it. So there are multiple reasons to treat the long-term non-progressors, but no one really knows about the elite controllers. So 80% will go there in 10 to 15 years, and this is all if there's no intervention. This is natural history of HIV. 15% in 2 or 3 years, poof, they're there. And the other 5%, they never get there.
Gotcha. No, that's really interesting. And yeah, you mentioned it's elite controllers. They're undetectable. They've got the really good T cells or antibodies or something.
For some reason, we don't know.
Right.
Yeah, that's amazing. But then the non-progressors, they can transmit it. It just doesn't ever get to a point where it's really negatively affecting them. I remember back in the early to mid 90s, like if you knowingly gave somebody AIDS, that was considered like a serious crime. It doesn't seem to be that way anymore because it's become less doom and gloom, less of a stigma. But I remember there was some guy in New York City who gave like 40 different teenagers AIDS or something, and it was like this huge thing. So it really has evolved and changed over the years. It's pretty amazing.
And there are still places where, you would go to jail if you if anyone knew that you deliberately
It's
went out
attempted murder
to try,
if you
right?
do.
Exactly,
Yeah.
exactly.
So,
But
Theo,
these,
let me, and we're really monopolizing your time here this evening, and I want to bring this episode and this discussion to a wrap. I got a couple of more questions, and we're going to continue this because it is one of the most important subjects that still exists. And even though it does seem in the colloquial press with everything else we have going on in our partially disintegrating society that it is not as big a deal anymore, and it is. And I want to know from you, with your 50 years of thought on this at this point, how can this be ended? How can this be prevented? How
I
can
mean,
AIDS be stopped?
so I mean, I'm a big believer in the HIV epidemic um, efforts here by our government. I mean, everybody needs to be tested. Everybody. Testing, testing, testing. Did I say testing? Testing. And if you're positive, you need to be on medication. You need to be on medication. You need to be on medication. We have options now. Instead of taking a pill every day, you have a long-acting injectable. And so you don't have to take a pill every day.
Just to let you know, you told me to get tested in 1994, and I did.
Testing is a good thing. It's always a good thing. And if you're at risk for HIV, then you should be on PrEP. If the test is negative and you're at risk, then you should be on PrEP. PrEP. If you take those things together, I mean, the CDC also adds, okay, if there's a mini epidemic somewhere, you need to pounce on that. That's sort of the third part of ending the epidemic. But I mean, you need to actually test people, put them on medication, and if they're at risk, you need to put them on PrEP. The issues that we're working with now is that we need to develop more options for people who are both living with HIV and who are at risk for HIV. Because the best option is the one the patient will take. And we need more options because, first of all, there are people who could never take a pill every day. They just couldn't. I mean, you can say, hey, this is easy. You can be undetectable. And they just can't do it. They can't take a pill every day. And then there are people who are like, stick a needle in me. You have lost your mind. So you have to have more options. What are more options in terms of HIV treatment? Taking pills once a week. That would be another option. There are other options that we're working to develop so that you would think the more options we have, the more likely we're going to actually be able to get everyone who is living with HIV on the medication that they are going to take for the long term. And the same thing for prevention, because again, so many of my patients are like, I can't take a pill every day. And then there are people who say to me, I can't do injections. Now I have to admit, with this last one where it's every 6 months, a lot more people are like, well, maybe I can get away with taking something every 6
Seems
months
pretty easy.
to
Yeah.
prevent
Every
HIV.
6.
So I mean, so for me, and people can't have to still remember it's a pandemic. It's a pandemic because HIV has become so. Oh, child, that was just disease of the 90s and early 2000s. We have all these other diseases. We have Ebola. We have COVID. I mean, HIV is so passe, and I'm like, hello, people still do die of this. I mean, even though we suppress people, and I expect people to live just as long as anyone else that's not living with HIV.
So really, at this point, there's no difference in life expectancy?
There isn't, but there are some real obstacles in living that life. So HIV causes what we call, even when you're undetectable, a condition known as chronic inflammation. Chronic inflammation. It's like your body is trying to get rid of this virus.
Yeah, I know.
And in doing so, it makes your blood vessels way more sticky. And so that means the cholesterol can actually accumulate far more quickly, cause an obstruction, and you have a stroke or heart attack. So in general, we tend to see strokes and heart attacks 10 to 15 years earlier in patients living with HIV compared to people who are not living with HIV. So they're real obstacles in
secondary and tertiary consequences
to living the same life.
You don't want to get it.
Right.
So it's not a death sentence, but you don't want to have it.
Right. You got it, Steve. There's still a reason not to want to acquire HIV. And I always have to walk a fine line because I can't scream too loudly in front of my patients living with HIV. Well, you don't want to get HIV because, you're supposed to be uplifting them and showing them, hey, you can live the same life. But at the same time, I have to tell my people who are not living with HIV, I'm telling you, you do not want to acquire HIV. And here are some of the reasons why.
So, ending this episode up, and we hopefully are going to have more discussions on this, especially as with many things, technology and the research and the science itself gets more advanced. Other than your innately positive personality, which I have experienced for the last half century, what makes you really hopeful, Theo?
I'm really hopeful because I see new options coming. And I see that people are really responding to these options. And as I mentioned earlier, I was really surprised. I said, oh, you can take a pill every day and you're doing well. And so many people were doing that. And then when I mentioned there was another option, this is when I found out from people who had never said anything before that the option that they had no choice but to accept was not one that they felt was giving them quality of life. And the new option I was actually presenting to them enhanced their quality of life. So, in a setting where life, or particularly medical practice, where you have patient centered care, where you hear the voice of the patient rather than the doctor just dictating what happens to you, the patient is saying, hey, this is how my life can be enhanced or my quality of life be maintained or enhanced. The development of options is what's exciting me because I feel that I'm better able to take care of my patient as I do my part to end the HIV epidemic.
All right. Well, with this solemn and very important subject and that very positive moment, gonna end this episode as Theo. We've utilized your time way beyond what your family there is finding acceptable, I think. We'll be back on. We will have more discussion about this subject. And again, audience, I really want to remind you, please listen to everything that Dr. Theo Hodge, one of this country's foremost experts on this subject, despite him rolling his eyes at me right now. You all can't see it, but I can, and he's trying to be humble, which he is. But what I said was absolutely 100% accurate. So, Theo, want to say goodbye to everybody, or say until next time, like Paul McCartney does?
Until the next time. And thank you so much for having me, Don. As always, it's an absolute pleasure.
Thank you, Dr. Theo. It is a pleasure.
And I will say to the audience again, no matter what we're doing, no matter if we're trying to get up to the highest altitudes on the planet, or we're trying to get to the lowest points in the lowest and most deepest canyons, or we're discussing artificial intelligence, or we are battling humanity's greatest foes and diseases. Remember one thing, and one thing always that will help you run your life, that all at-bats are situational.